Okay, well, we have a small but very important group here, so just wanted to welcome everybody and officially open the ERAS Gynecology session. So we have 2 sessions this morning, each with 3 speakers, and then we'll kind of see how things go, but the whole idea is to have a bit of a interactive discussion at the end, looking at evidence gaps for ERAS in gynecology. So our first speaker is Dr. Stephen Bish from Canada, and he's going to speak to us on outcomes assessment of ERAS in obstetrics and gynecology. So welcome, Stephen.
Thanks, Greg. And thanks everyone for waking up bright and early this morning and braving the morning hours to listen to something stimulating about outcomes assessment. And I think it's important for me to say that this isn't just about outcomes assessment in ERAS. This is about quality outcomes assessment and what we can use down the road. I have no financial disclosures. The only disclosures I have are that these photos of Alberta are a little bit biased in that, Alberta is beautiful at all times of year, but usually it's blanketed with some snow. So you're seeing most of the summer, which lasts for all of 2 weeks in the province. That's not true, but. So this morning we're going to be talking about a brief overview of the current evidence of ERAS in obstetrics and gynecology, and this is rapidly updating. The slides are already out of date because people keep publishing at a record pace. We're going to talk about 2 historical measures for assessing risk of bias, and sometimes we use that as quality as a proxy. But we're also going to be talking about a tool for improving consistency in ERAS publication and identifying challenges with current compliance reporting and how that affects the way we're looking at our data. So currently, you'll already see that my obstetrics slide is out of date. We now have a meta-analysis showing close to 14,000 patients total for ERAS and cesarean section. We have a recent published meta-analysis by my group on gynecologic oncology, and a lot of those studies include general gynecology as well. That encompasses approximately 6,400 patients. And what we found across the board is that ERAS, not surprisingly, improves length of stay, improves opioid use, cost, complications, and readmission, at least in our study. And you can see the forest plot there showing that we have a significant reduction in complications across the studies that reported it. Additionally, other things that are becoming more important as we look at the obstetrics literature, time to first breastfeeding, and outcomes for maternal and baby are showing some improvement. So, with all that evidence, the question is, why are we still doing research? We've got busy lives, we've got to go put this into practice. What do we need to keep doing? Why are we still doing this? And the answer is simple. We have a lot of unanswered questions still, especially as we move into the obstetrics and gynecology population with healthier and healthier patients. We start thinking about the extremely rare but devastating consequences of a surgical intervention or non-intervention. And the simple answer to find out rare outcomes is numbers. We need a lot of them, and we need that data to be able to be meta-analyzed and put together. Additionally, as you'll see through my talk, that we need to start focusing more on patient-reported outcomes. A number of the presentations over the last couple of days have reported that we're very good at proving this length of stay and complication improvement, but what are the patients saying, and are we using validated metrics to do that? Additionally, a lot of the programs that have been implemented have been rolled out in academic centers and major centers of excellence. And we need to start looking at how we can make ERAS available for everyone, not just the pillars of excellence, but every hospital so that everyone can benefit. Additionally, ERAS is an evolving process. As we all know, the guidelines change every couple of years as the evidence gets updated. And so we really need to just keep changing and assessing what we're doing. Is it the right thing to do, and is it still improving outcomes? It's sort of a lifelong learning exercise. And finally, we also need to look at where compliance sits. What elements of ERAS actually need to be implemented to improve compliance and improve outcomes so that we can simplify the ERAS guidelines to make them easier to implement. So, what is the quality of the data? And I think the key takeaway point here is that all the data that's coming out is high quality. We're not going to be judging anyone, but what we do need to do is assess the risk of bias in our studies. As you know, many of our studies that come out in ERAS, especially in obstetrics and gynecology, are the pre-post cohort studies. And there's a lot of risk of bias in those. So tools like the Newcastle-Ottawa score are something that we implement in meta-analysis studies to assess the risk of bias in any particular study so that we know what we're dealing with and take things with a grain of salt. Obviously, randomized controlled studies, when they're properly performed, can minimize bias, but you still need to look at them because alterations or deviations from protocol, issues with randomization and allocation concealment can also lead to inherent bias in the studies, and we need to be aware of that so that when we're looking at, say, negative studies or even positive studies, that we are understanding the bias and which direction that bias is heading in. So this is data from our study, from the meta-analysis, and apologies that a lot of this is going to be gynecologic oncology focused because that's the data I've looked at most closely. As you'll see there, that on the left side of your screen, the data for the randomized controlled trials are very good. Overall, the quality is high. There are some inherent risk of bias within the studies, and we take those with allow that to interpret the results accordingly. What's really important to see here is that on the right side of the screen, the cohort studies, we do very well with the assessment or selection of our cohorts. A lot of the times we're using the entire population, which minimizes bias that we're pulling from in the way we ascertain our cohorts. What we really need to be starting to focus on is the yellow column there, the comparability of the cohorts. That's either done with matching or with statistical methods like regression analysis, and you can see that a lot of the studies that have been published haven't had that regression component, and I've seen that across the board, including new studies. It's statistically sometimes complex, but easily doable, and it's a matter of collecting the right data. So how do we standardize our data? And we just talked about the risk of bias, but there's more to creating high quality data long term than just assessing and minimizing the risk of bias. As ERAS proliferates, we see a lot of new studies, which is excellent, but we also have seen that variation in the studies and the protocols has changed. This discrepancy makes systematic review and meta-analysis difficult, and this is important when we're looking at those rare outcomes because we need that data to be able to come together smoothly so we can answer the questions very definitively. A meta-analysis is only as good as the studies that go into it, and so we need to make sure that every study that comes out, no matter how small or big, is well done and consistent. To that end, Kevin Elias and his group have put out an excellent checklist by the Recover checklist, which I think most of you are familiar with. But it's a 20-item checklist that improves the ability to do a systematic review. It minimizes spin and overestimation and improves compliance reporting by having set guidelines to follow, which are very similar to checklists that have been done for randomized controlled trials like the consort diagrams, which have overall improved the quality of studies that have come out. It also makes it easier to do a systematic review by making titles very clear. There's no creativity in the titles. It's meant to be very easy to search within our databases. So we applied the Recover checklist to every study in gynecologic oncology, and this was in our paper as well. And what we found with the studies that have been published so far is that there is a limited description of audit and compliance. We found that few validated patient-reported outcome tools were used. And we also found that compliance with individual elements were rarely listed. And again, the same thing that we saw with our assessment of the Newcastle-Ottawa score, we're having regression is not always performed to assess for those potential biases in our pre-post studies. Speaking a little bit about compliance itself, why does it matter? Well, Iniesta and their group demonstrated in 2019 that compliance over 80% was associated with fewer complications and shorter length of stay. This is mostly with the elements in fluid resuscitation, early mobilization, early nutrition, and catheterization. This gives us an idea of what sort of elements are really driving the benefits we see from ERAS. When we looked at the association between compliance greater than 50 to 75% versus greater than 75% in our meta-analysis, we weren't able to redemonstrate that finding. And I don't think it's because it doesn't exist. It has to do with difficulties in reporting. and the consistency in which compliance is reported along those studies. Again, the meta-analysis is only as good as the data that goes in. As you can see, we have a number of studies. Not all of them reported compliance, but those that did reported on a wide number of different elements, and they had a wide variety of overall compliance despite well-implemented programs. So what is high compliance? Well, we've defined it as over 75 to 80%, but this can be biased in any direction. You can imagine that if you're reporting more compliance elements, but those compliance elements are things you're already doing, then you're going to artificially increase the compliance you have across the board. Where alternatively, if you're not reporting compliance elements that are very difficult to achieve, say people are keen to implement VT prophylaxis as very standard of care, but people are still very hesitant to implement early enteral feeding, you're going to artificially bias your numbers high as well because you've left out the difficult things to achieve. The other question is, what is compliance? And so we've talked a lot about individualizing care for patients, and what I'm here to say is that non-compliance doesn't mean non-adoption. Maybe that was the case with early adopters, but this is becoming standard of care. Non-compliance also doesn't equal improper care, because not every every patient is a candidate for unaltered ERAS protocols. An example being someone with a history of upper GI bleeds and NSAIDs. In a lot of studies, they would be listed as non-compliant, which again would throw our results off. These are appropriate deviations from patient care. And the question is, do we report that as appropriate deviations, or do we start individualizing our guidelines to say, if this patient has this condition, then the guideline would be to do this? Just something to think about. So in reflection, the evidence for ERAS in obstetrics and gynecology is growing. We want to make sure it grows well. We still have a lot of work to do, and in order to ensure that that work bears fruit, we need to standardize our reporting, especially controlling for confounders in every single study, and we need to start the discussion about what constitutes compliance versus deviation. I want to thank everyone for their time this morning, and happy to take some questions.
Why don't you stay up here, Steve? Okay, thanks a lot, Steve. Super interesting talk, especially I think it's really relevant as the evidence base continues to grow in obstetrics and gynecology, that we have sort of a way to assess these studies. I think, any questions at all from the group? I thought we would just kind of go through the talks, and then maybe at the end of the session, if we can maybe discuss some of the questions at that point. So our next speaker is Dr. Christopher Jankowski from the Mayo Clinic, and he's going to speak to us on anesthetic and analgesia in gynecologic surgery. Welcome, Chris.
Thanks, Greg. Good morning. How many anesthesia providers do we have in the room? Oh, wow. Way more than I expected. I'm going to give kind of a 30,000-foot overview of our approach to anesthesia and analgesia in ERAS for gynecologic surgery. And as I mentioned at dinner last night, this is going to be an entirely data-free presentation. It's more conceptual. So folks in anesthesia, I apologize. I have no disclosures. So stepping way back, I think it's good for us in anesthesia particularly to look at what the goals of enhanced recovery are. In my specialty, we spend a lot of time thinking about things that are maybe really cool intellectually for us, and kind of minor sort of outcomes. But if we step back, this is a patient-centered process. And our goal as anesthesiologists and nurse anesthetists is to improve the patient experience throughout the episode of care. If we don't do our job well in anesthesiology, we can completely wreck an ERAS program, because in the middle of an operation, if we say give a lot of opiate, everything downstream goes away. So we're kind of the linchpin of what happens during an ARIS protocol, even though that much of it happens preoperatively and postoperatively. And again, we want to replace our traditional practices with an evidence approach to care. I put this slide up here just to remind everybody that overnight fasting isn't necessary. And we see this even at our institution, that services are asking patients to stop eating at midnight, stop drinking at midnight, and their operations sometimes start at 3 in the afternoon. These are the ASA guidelines for perioperative fasting, most recently updated in 2017. As anesthesia providers, it's important for us to make sure that we're educating our colleagues in our institutions to continue with this. So a linchpin of enhanced recovery protocols is having a standardized anesthetic protocol. And I'm just going to go through kind of some of the principles that we adhere to with this. The first is avoiding routine perioperative or preoperative sedation. There's no evidence that this is necessarily helpful in a standardized way. In individual circumstances, it may be reasonable to give some sedation, but giving sedation preoperatively delays recovery. So we want to avoid this to the extent we can. Regional versus general anesthesia, gynecologic surgery, encompasses a wide, as everybody in this room knows, encompasses a wide range of procedures, and there are some that are really amenable to regional anesthesia. However, there is no data to suggest that one technique is in particular better than the other. So the approach I recommend that you take at your institutions is to look at what the broad practice is in the institution. If there's a bunch of providers who are more comfortable with regional anesthesia versus general anesthesia, that may be the way to go, but there really is no data to suggest that one is better than the other. In general, with enhanced recovery, short-acting anesthetics are what we want to use. If a practice chooses to use volatile anesthetics, we want to use short-acting anesthetics. So these are desflurane and sevoflurane as opposed to isoflurane. However, there's a tremendous impact with desflurane relative to sevoflurane and isoflurane with regard to climate change, surprisingly enough. And the anesthetic gases that are used in this country every year are equivalent to one coal-fired power plant in terms of their environmental impact. And desflurane lasts in the atmosphere 10 years as opposed to 2 to 3 years for the other agents. So even though desflurane has some very favorable pharmacokinetic properties, we try to avoid it when we can. There's been more popularity recently of using total intravenous anesthesia, or TIVA. This is a propofol-based anesthetic approach. There are advantages both environmentally, possibly with regard to immediate recovery. Propofol-based anesthesia is also a very good approach to help avoid nausea and vomiting. So in our practice, we're using more and more of this. Within a standardized anesthetic protocol, we try to avoid opiates as much as we can, and we do this via adjunctive agents intraoperatively. There's a lot of data recently on the use of ketamine. Ketamine may be especially effective for decreasing the incidence of chronic pain. Lidocaine is a benign agent that also decreases opiates, decreases the need for intraoperative anesthetic agents, and it improves recovery. One of the issues that comes up with lidocaine is whether or not it's compatible with the use of some of our extended release local anesthetics such as Exparel. There are no data to suggest that there's a problem using lidocaine in the doses we use for lidocaine infusion intraoperatively. Dexmedetomidine is a unique agent that's used. It has been used primarily for ICU sedation, but it's being used more and more as an adjunctive agent for general anesthesia. It reduces opiate requirements and improves a number of recovery parameters. One of the issues that kind of flies under the radar is whether or not neuromuscular blocking agents need to be reversed. And traditionally in anesthesia, in some practices, if the case was long and there wasn't the need for a lot of neuromuscular blockade, practitioners would not fully reverse patients. And there's a definite incidence of respiratory complications related to inadequate reversal. So within an ARIS protocol, it's important to make sure that all your neuromuscular blocking agents are reversed appropriately. I'm not going to belabor this point, but because you're going to hear a little bit later this morning from the world's expert on fluid management within an enhanced recovery pathway. But the goal with enhanced recovery is to maintain euvolemia. And obviously for a repair operation, the fluid requirements are going to be different than a large oncologic operation. Euvolemia in terms of outcomes becomes a more important issue on major cases. You'll hear from Dr. Bakum-Gomez shortly about bowel preps. In general, if bowel preps aren't occurring and patients are following the appropriate guidelines for MPO status so that they're taking clear fluids in up to 2 hours before surgery, there's no need to try to make up for fluid losses associated with those two things. So we cut back on our fluid administration considerably. The important thing, I think, for all of us to remember is that fluids are a drug. And I've got 14.2 Lay's potato chip bags up there, single serving bags, and that's the amount of sodium that is contained in a liter of of Ringer solution. So you know, I have 2 bags of potato chips, and I can't get my shoes on the next day. There's a lot of salt in fluids, so we need to think about that as we're managing fluids. Prevention of hypothermia. This is pretty much standard practice within the anesthesia community, but it's exceedingly important because it's associated with a number of adverse outcomes. There are a number of modalities by which we can do this. None is particularly superior to the other, but I will point out that warming the room is probably a good idea. The biggest source of heat loss during an operation is from radiant heat loss. So the fact that a cold operating room acts as a heat sink is really important. So warming the room before the case starts, cooling it down after things get going and the blankets are on is probably reasonable. We need to maintain comfort for the people in the operating room, but at the same time, keeping the room itself warm is very helpful. There are some studies that demonstrate that if you do preoperative and postoperative warming, there's improved outcomes as well, even in the incidence of not having hypothermia. This group takes care of a bunch of patients that are exceedingly high risk for nausea and vomiting. Major risk factors, independent risk factors include gynecologic surgery, laparoscopy, non-smokers, which is the majority of our patients anymore. In general, patients need to have more than 2 antiemetics, and these can be across a variety of drug classes. As I mentioned earlier, using total intravenous anesthesia is helpful. Minimizing opioids. Euvolemia is important. Hypovolemia is associated with nausea and vomiting as well. Nitrous oxide is a strong antiemetic, a strong emetic. So we prefer to avoid that. And then in the last several years, there's been a new drug for neuromuscular blockade reversal called Sugamadex, which has a number of favorable properties with regard to just the reversal portion of its action. But traditionally, we've used cholinergic agents to reverse neuromuscular blockade, and those are associated with nausea and vomiting as well. So we recommend using Sugamadex for reversal. Multimodal analgesia, we've heard a lot about during this meeting, and we'll hear more about. In our practice and in the guidelines, we recommend using acetaminophen and celecoxib preoperatively. Gabapentin has traditionally been used, but last year and in the past several years, there's been a number of studies that have come out that show an association between perioperative gabapentin use and adverse respiratory events. And in fact, late last year, the FDA issued a black box warning for gabapentin in the perioperative period. So we've gone away from it at our institution. There is some debate as to whether or not this is a really significant issue. It seems to be that only with higher doses, 600 milligrams or higher of gabapentin perioperatively, and an elderly patient seems to be where the non-sweet spot is for gabapentin. But I'd recommend that as you develop your pathways at your institution, you consider whether or not this is really a necessary component of it. Intraoperatively, we talked about some of the adjunctive agents we used. Postoperatively, we want to avoid opiates, and one of the issues that is, or one of the approaches that's very helpful is to schedule your non-opiate medications, not make them PRM. There are a number of regional techniques that are available. These include wound infiltration, TAP and other blocks, intrathecal opiates, and epidurals. There's not a lot of evidence to suggest that any one technique is better. At our institution right now, we've got an ongoing study looking at whether or not intrathecal opiates are better than wound infiltration or additive to wound infiltration with local anesthetics. In general, for gynecologic surgery, epidurals are probably a little bit overkill. They're kind of the gold standard in terms of pain relief, but they're not necessarily associated with improved outcomes. So we have a joke at our institution, and it's how many Mayo Clinic attending physicians does it take to change a light bulb? And the answer is change. We don't change. And I think the thing is with enhanced recovery is that the evidence is out there. It's very clear that it works, but it's difficult to get folks to change what they've been doing. And the way to do this, I think, is to meet people where they're at. If you can get providers to adopt a portion of an ideal protocol as a starting point, that's great, because you can begin to move towards an ideal protocol. We need to be dogmatic about the goal that we have, which is to improve patient outcomes, but not the details of it. And particularly in our specialty, where there's a lot of different ways we can approach this, and really not much evidence that one approach is better than the other. I wouldn't sweat the details on it. We want to improve recovery. We want to minimize opiates, and we want to make sure that patients are adequately fluid resuscitated. So I wouldn't argue with people over the details. We want to develop a standard within our institutions that everybody can do, so that all patients who come to a particular institution are getting the best care that institution can offer at the moment. And then the final thing is just to develop an improvement mindset. So, we heard about compliance just now, and collecting data about your processes and your outcomes is very important, and it gives you a basis upon which you can begin to improve. So that I think is probably as important as any particular detail within a pathway. And I'll take some questions later. Thank you.
Thanks so much, Chris. Very thought-provoking presentation. Our next speaker is going to speak to us about something that we just can't seem to sort out what the right approach is. So hopefully she's going to clarify it all for us this morning. So Jamie Backham is going to give us a talk on role of bowel preparation and when to divert our patients. Jamie.
Thanks, Greg. Good morning, everybody. Yeah, I don't know that I have all the answers yet, so. So I have no relevant financial disclosures. Learning objectives, I'm going to talk a little bit about bowel preps in general, and it's important to understand that just because you say bowel prep doesn't mean that they're all the same. We'll talk about some of the current data on mechanical bowel preps plus oral antibiotic prep, as well as mechanical bowel preps alone, oral antibiotic preps alone, as well as no bowel prep. And then some management strategies to reduce rectosigmoid anastomotic leak. So this is technically kind of two talks. And I'll pivot a little bit after talking about bowel preps to talk about anastomotic leak prevention. So we shall not cease from exploration, and the end of all our exploring will be to arrive where we started to know the place for the first time. So back in 1970s, Nichols and Condon published their bowel prep, which was an oral prep of neomycin and erythromycin or metronidazole, which I think sounds still fairly familiar because it's typically part of oral antibiotic prep today, as well as the mechanical bowel prep. And there was evidence even before that, published in the 1940s, of various oral antibiotic preparations that were tested, varying bioavailabilities, and settled on a variety of combinations that usually include something along the lines of neomycin plus metronidazole. And there was also early evidence that suggested lower rates of septic complications. A randomized trial published in 1977 that showed that oral antibiotic prep and elective colorectal surgery decreased septic complications. So what about today? So the data's mounting. This is not a data-free talk. The data is mounting that suggests that oral antibiotics, the higher the utilization of an oral antibiotic prep in an institution. This is a large study of 112 VA hospitals. You can see that the higher the rate of oral antibiotic use prior to elective colon surgery correlated with a lower rate of surgical site infections, so basically half the rate. So the data is out there that suggests that oral antibiotics before bowel resection does decrease the risk of surgical site infections. So before I continue on, I want to at least set the definitions. So mechanical bowel prep is really anything that's cathartic that's taken by mouth. So whether it's osmotic or non-absorbed osmotic, combination of an osmotic, cathartic plus a laxative, but basically enemas and suppositories, anything per rectum is excluded. That's not considered a bowel prep. So mechanical bowel prep. And mechanical bowel prep itself is actually probably quite dangerous and potentially harmful. So there's a lot of data out there, randomized trials of mechanical prep alone versus no prep, and in a meta-analysis of 7 of those randomized trials, there were actually higher complication rates associated with mechanical prep alone. There was a higher rate of anastomotic leak, greater rates of infection, both organ space as well as superficial surgical site, and higher rates of reoperation. Plus, in addition to all of that, includes the preoperative dehydration, as Chris just spoke about, the aspect of catching up in the setting of trying to keep patients euvolemic. Also, electrolyte abnormalities, especially in our aging population who may be on diuretics. And then there's a large body of literature on patient dissatisfaction with bowel preps. So, but why do we still have mechanical bowel prep as part of this? it likely facilitates the transit of oral antibiotic prep through the colon. And so a couple studies that have been done using the NSQIP targeted colectomy cohort. This is the earlier of the two, about 8,000 patients. And this was, of course, a retrospective cohort of assessing no prep versus mechanical prep alone versus mechanical prep plus oral antibiotics. And not surprisingly, mechanical prep alone, there was no impact, but when you combined that with the oral prep, there was a 30% decrease in ileus, and anastomotic leak went down, and all of these are statistically significant, and this was compared to no prep, and then surgical site infection went down by 60%. But I'm going to take a little segue into surgical site infections because that's one of the main drivers of using a bowel prep is that surgical site infections are lower. Well, I think it's important that we recognize, and I think we all know this, that surgical site infections are multifactorial. Some of these we can control and some of these we can't control. And it does take more than a bowel prep. So this is actually a large consortium of Michigan hospitals, 24 hospitals, that implemented a surgical site infection reduction bundle. One of those bundle elements was mechanical prep plus oral antibiotic prep. And what you can see here is that of the 6 items that were in that bundle, from a compliance standpoint, if only one bundle element was implemented or utilized, the surgical site infection rate was almost 18%. But if all 6 of them were included, it was down to 2%. And this means that this is a multifactorial component or a multifactorial problem, and just a bowel prep alone is not the linchpin. And in our practice, in our institution, we actually did 2 different quality improvement projects. The first was led by Dr. Bob Sima, colorectal surgery, and this was in the era of no bowel prep in colorectal surgery. So enhanced recovery came along, and in the implementation of that, the bowel prep was discontinued for a while in our colorectal surgery group. We did the same in our gynecologic oncology practice. And I will also disclose that since 2009, I have not given a patient a bowel prep except for when they need a colonoscopy. So when my patients prior to surgery, they do not get an oral prep. But using a bundled approach, we actually, both in the colorectal surgery group as well as in the gynecologic oncology surgery group, were able to reduce surgical site infections without needing a bowel prep. So it's a 17-point bundle, but a lot of these are best practices like wash your hands, take care of your incision, and then also using like a closing pan where we're using instruments that haven't touched an area that was contaminated with normal flora, like the colon or the vagina. Our experience, so this is Bob Sima's data, over 50% reduction in surgical site infections in colorectal surgery, and then in gynecologic oncology surgery, way down in the corner, we were able to get our surgical site infection rate down to 2%, and this is in patients that have ovarian cancer debulking with a bowel resection, and these patients did not have a bowel prep. This was in the era of enhanced recovery. And then in gynecologic surgery alone, and I say alone because this was a very large data warehouse study that actually Dr. Sean Dowdy led, using Optum Labs data of almost 225,000 hysterectomies. And this was a comparison between no prep versus a prep. And a prep could have been a mechanical prep with or without oral antibiotics. So that's important. But there was no difference in surgical site infection, anastomotic leak, or morbidity. But when you look at this table, you see one p-value that is actually statistically significant. And in the bowel prep group, there was a higher rate of postoperative ileus. So it wasn't that it improved anything, it actually worsened outcomes. And this table is just abdominal hysterectomies, but when the data was sliced and diced and abdominal hysterectomies plus bowel resection were looked at, there was no difference in surgical site infection, leak, morbidity, or ileus. So, I'm giving a lot of data, and the question, and as Greg asked for the answer to the questions, I'm not sure that I have it, other than the fact that we do know that mechanical PrEP alone is probably harmful. But what about oral antibiotic PrEP alone? So there are a couple studies out there. This is the second of the NISQIP targeted colectomy studies, 27,000 patients, almost 28,000. And when it was sliced and diced down to mechanical PrEP alone, oral antibiotic PrEP alone, or mechanical PrEP plus oral PrEP, you can see that and all of these odds ratios are actually significant if there's a number there. So mechanical PrEP plus oral antibiotics or oral antibiotic alone decrease the rate of all surgical site infections, organ space surgical site infections, so abscesses, and anastomotic leak. Mechanical PrEP plus oral PrEP decrease the risk of wound dehiscence, which is likely more along the lines of a neglected surgical site infection or a superficial surgical site infection. But mechanical PrEP alone, as you can see there, it had no impact. The ORALEV randomized control trial was published last year, and this was a randomized trial of oral antibiotic PrEP versus no oral antibiotic PrEP. No patients had a mechanical PrEP. So basically randomized between just antibiotics by mouth the day prior to surgery versus no antibiotics. And then these patients also did get IV skip antibiotics. So Cipro and Flagyl by mouth the day prior to surgery, and they actually saw a 60% reduction in surgical site infection. So there's something about the oral antibiotics. So with that, the mounting data supports oral antibiotics, likely with a mechanical PrEP to get those antibiotics completely through the GI tract. But we do have some caveats, and that is that thus far there's no randomized trial of oral antibiotic plus mechanical PrEP versus oral antibiotic PrEP alone. There's varying surgeon approaches. As I already mentioned, I haven't given a patient an oral bowel PrEP since before I came on staff. And so that spectrum ranges anywhere from abandoning any bowel PrEP to society guidelines in the United States for oral antibiotic PrEP if we're giving a patient a mechanical PrEP. So American Society of Colon and Rectal Surgeons, as well as the Society of American GI and Endoscopic Surgeons. In our institution, our colorectal surgeons have gone back to giving a PrEP, which includes oral antibiotics as well as polyethylene glycol the day prior to surgery. But surgical subspecialties are unique, and our surgical field can be unique as well in the setting of a straightforward elective colon resection versus a large ovarian cancer debulking in a patient with ascites or who's had previous chemotherapy. And I do think that there are some outstanding questions. So while I can't give you complete answers, we can pose some additional questions. As Chris brought up, what are some of the additional counterbalances, especially such counterbalances such as euvolemia? And I think one of the other things that's really provocative that we're starting to really kind of just scratch the surface on, and that is when we provide oral antibiotics to patients to prep their gut, what happens to the microbiome, and how does this actually impact recovery as well as long-term health? So opportunities for new questions to be answered. So I'm going to pivot a little bit to talk about anastomotic leak. This is such a catastrophic thing that can happen. And so, but on the other hand, I don't know anybody who really enjoys having a diverting loop ileostomy. So it's a balance of risk and benefit. In our practice, or in our institution, as I mentioned before, our bowel prep practice was discontinued in 2009. We did do a prospective quality improvement project, recognizing that we needed to do something to decrease the rate of anastomotic leaks. We were sitting at about 8%, which just didn't feel quite, it felt like we had some room for improvement. And so Dr. Carrie Langstrat actually led a prospective quality improvement project that implemented or utilized criteria for when to divert after a rectosigmoid resection. You can see the list there. So low albumin, prior pelvic radiation, if we did 2 large bowel resections, a very low anastomosis, a non-tension-free anastomosis, although we definitely want to make sure that we are not providing a patient with a anastomosis that's on tension, or if the bowel is compromised. And then part of the practice in assessing the anastomosis includes doing a leak test with a proctoscope, measuring the distance between the anastomosis and the anal verge, and then near-infrared imaging of perfusion. And so even though the data out there in Pillar 3 unfortunately did not show a difference in anastomotic leak with near-infrared imaging when patients were given IV ICG and the anastomosis was imaged with a pinpoint. It's important to note that this study actually closed early because accrual was decreasing. And so it was actually underpowered. And you can see the anastomotic leak rate there with both standard assessment as well as the near-infrared was about the same. What we were able to accomplish with our quality improvement project was to get down to an anastomotic leak rate of about 2% by implementing just high-risk criteria, and in those patients, we divert them. An ongoing study that Dr. Oliver Zvanovic at Memorial Sloan Kettering is leading is ARIA-2, which is a phase 3 randomized trial of ICG plus pinpoint versus standard assessment, specifically in ovarian cancer. And this is a study they're aiming for about 580 patients to be enrolled, and it just opened in May of this year. So additional questions and answers to come. Somehow, I'm not advancing. I only have one more slide. There we go. Perfect. Okay. So in conclusion, mechanical bowel prep, I think that's one answer that we definitely have. Mechanical bowel prep alone doesn't improve postoperative outcomes, likely increases complications, and may potentially cause more harm than good. There's mounting data that supports oral antibiotic prep, and in that setting, using a mechanical prep to enhance transit. It does appear that it contributes to reducing surgical site infection and anastomotic leak in ileus, but there are also bundles associated with reducing those postoperative complications. Prepping the bowel with oral antibiotics alone may achieve reduction in surgical site infection. Like I said, there's one study now that we have level 1 evidence for. And anastomotic leak can be reduced by about 70% if we divert patients if there's a high risk of anastomotic leak. And intraoperative near-infrared perfusion imaging trials are ongoing. Thank you.
Excellent. Jamie, you truly are the expert of bowel prep, especially given the fact that you have never given it. But I too am very proud to say that I have never given mechanical bowel prep, so I'm glad that we can be strong together. So I'll invite Sean Dowdy up, who will be introducing the next session. Thank you.
Hey, good morning, everybody. I'm Sean Dowdy. Nice to see everybody here. We will start with Dr. Gretchen Glazer, who is an associate professor at Mayo Clinic, and she's also our program director for the residency in her spare time. And she's really put a lot of work into bringing this data together. I really appreciate all the work she's put into this, and she's going to talk to us about pharmacogenomics and if we can tailor the dosing of opioids. So there's been a lot of discussion about reducing opioid use, and maybe we can have a more individualized approach to that. So thank you, Gretchen.
All right, good morning. Thank you so much for inviting me to talk today about our pharmacogenomics project and how this emerging field may really help us to tailor opioid dosing for our gynecologic surgery post-op patients. So the picture I have here is of Antonio Brown. He is a clothing tailor and the owner of Mi Montuno in the Prospect Heights, Washington Avenue neighborhood of Brooklyn, New York. And he looks at himself as an artist. So he makes custom men's suits that mix colors and fabrics to make one-of-a-kind garments. And it's my hope that we can continue to refine our patients' post-operative opioid regimens to create something similar, a really tailored experience that takes every individual patient's makeup into account and make unique plans for them. So I have no disclosures. So obviously everyone here is no stranger to the enormous gains made by enhanced recovery after surgery protocols in terms of optimizing patient pain control in the perioperative and inpatient setting. This has been especially crucial as we know that while patients having gynecologic surgeries broadly have about a 1% risk of infection, they have a 6% chance for going from opioid naive to opioid dependent purely from the opioid treatment of their postoperative pain. So recently at Mayo Clinic, we have taken this a step further to the outpatient setting and have implemented and published a tiered guideline approach to prescribing opioids for outpatient use. So you can see here our opioid prescribing guidelines, which these were based on, how we designed them was based on a multi-center, multi-specialty retrospective cohort analysis that investigated discharge and refill opioid prescriptions. So basically we looked at all of that, then we made our guidelines and implemented them. And they included giving no opioids to patients who had had hysteroscopy and also no opioids if our patient had not taken any in the day before they went home. And then to our same-day hysterectomy and laparoscopy patients, we gave them 10 pills of 5 milligrams oxycodone. With patients with higher pain needs or who came in with a pain diagnosis, we consulted our pain service and then tailored their homegoing prescription to be whatever was kind of appropriate to add to their current regimen. So in our investigation from this study of over 1,200 postoperative patients, in whom 600 were managed with these guidelines, there was no change in opioid refills between those who were treated before and after the implementation, and their prescribed MME actually went down. Oh, sorry about that. Let me just see if I can. There we go. Oh my goodness. Sorry. So they're, yeah, oh my gosh. Yeah, okay. Their prescribed MME went down from 150 to 75, and so that was a p-value less than 0.001. And in our subset of our patients who you would expect to have the most pain, so these are patients with complex ovarian cancer surgeries, 100% of those patients felt satisfied with their pain control. So from this study, we really were able to see that even when you give patients far fewer opioids than were traditionally prescribed, they really had excellent control. So from this point, we hope to keep going, to take it even a step further, to be able to predict better which patients could we give 2 pills or 3 pills to, which patients could we just give none to, even after laparoscopy. And so this would take us even closer to truly individualizing. So pharmacogenomics is an emerging field which could help us to do just that. So this is defined as the study of the role of genetic variation in drug response phenotype. Or in other words, how a person's specific genetic makeup affects how well certain medications work for them. This variation is known in opioid therapy and also in many clinical applications, such as nephrology, anticoagulation, anti-cholesterol therapy, just to name a few. There are many genes that can be tested and examined as part of a pharmacogenomic testing, and depending on what drug you're trying to investigate, you pretty much tailor your panel to that. So pharmacogenomics has the potential to help remove the guesswork from the prescription of certain medications, which is really promising for our ERS protocols. And specifically for opioid prescribing, it would really help us address both ends of the spectrum, the patients to whom we're giving too much right now and the patients to whom we're giving too little. So the majority of opioids are processed by the CYP3A4 and CYP2D6 enzymes, with a more recent discovery of a few others such as OPRM1 and COMT. So the CYP2D6 gene is of particular interest to us because it is highly polymorphic. It has over 130 core alleles and significant differences in allele frequencies between geographic, ancestry, and ethnically diverse groups. And these polymorphisms in the CYP2D6 gene have an association with enzymatic clinical effect, with some having normal function, others having decreased function, and some with no function at all. And the main activity of CYP2D6 is O-methylation of codeine and tramadol to their more active metabolites, as well as conversion of hydrocodone and oxycodone into active metabolites. Hydromorphone, so that's another drug in our armamentarium, Dilaudid for postoperative pain control, is not processed through this pathway. A modified Delphi approach to obtain consensus among international CYP2D6 experts, who knew there were international CYP2D6 experts, but there are, led to the creation of this uniform system for translating genotype and diplotype into phenotype. And so here you can see one iteration of medication metabolizer status outlined. And in the most recent Clinical Pharmacogenetics Implementation Consortium guidelines from October of 2021, the top two categories have been condensed into one ultra-rapid category, but the system is otherwise identical. Essentially, each category defines how quickly a drug will be metabolized based on the enzyme of its corresponding gene. So ultra-rapid metabolizers may have decreased efficacy of a particular drug, while poor metabolizers have a higher risk for adverse effects. The FDA uses this information for drug labeling, and if you go to the FDA website, you can actually see 483 drugs that put pharmacogenetic information on their labels. And there are drugs, not opioids at the moment, but there are FDA-approved drugs for whom the label tells you which pharmacogenetic test to do before you give the drug. So here you can see the 2021 assignment of phenotypes, as I was discussing, that one category got condensed. But what I want to point out here is the activity score. So this is a quantitative way to measure the activity of alleles used to determine a patient's diplotype. And the diplotype is one maternal and one paternal allele, and that translates to phenotype. So in this scaling system, 0 represents no function, 0.25 to 0.5 is decreased function, and 1 is for normal function. And the total CYP2D6 activity score is the sum of the values assigned to each allele, which typically ranges from 0 to 3, may exceed 3 in rare cases. The incidence of metabolizer types varies between populations, but in general, the normal is the most common. So about 67 to 90% of patients will have a normal phenotype, whereas 0.5 to 5% are poor, about 1 to 11% are intermediate, and 1 to 20% are ultra rapid, really depending on your population. So now we know that patients with different genetic combinations of CYP2D6 can have different metabolizer status of our most common opioid medications. And the next question is, what can we do with this? How can we use this to tailor our patient care? So to answer this, in 2018, we initiated a study to compare perioperative opioid use and clinical outcomes by CYP2D6 status in women undergoing laparotomy for gynecologic pathology. In our cohort, 96% of the included laparotomies were being done for cancer, and there are currently several options for pharmacogenetic testing. The one that Mayo Clinic uses is a CLIA and CAP-approved pharmacogenomic gene panel, and it's called RightMed by OneOme. So at the preoperative visit, patients who consented provided a one-time buccal scraping. It's basically like a Q-tip in the mouth, to be sent to OneOme for analysis. And they were given education materials and described the rationale for testing. And they then had surgery and underwent their entire postoperative recovery, including outpatient, without the patient or the physician knowing their status. And once their postoperative recovery was complete, and they'd had their postoperative survey, as I'll discuss in a moment, then they received their results and a letter explaining the results, and also an offer to meet with a pharmacogenomics specializing pharmacist if they wanted to. Postoperative opioid usage and pain scores were evaluated by chart review for the inpatient period and with a phone survey that was planned for 21 to 35 days after discharge. And questions included how many of the pain pills prescribed had been taken, satisfaction with pain control, among others. This is the same survey that we had used for our prior guideline study. We had really good representation of our most complex patients in this cohort, with 96% for cancer, as I had said. About 69% of our patients were undergoing complex cytoreduction, and then another 20% underwent bowel resection. Of these enrolled patients, only 3% were classified as ultra-rapid, 58 or 60% were normal, 28% intermediate, and 8% poor. And this was consistent with multiple prior reports showing kind of this breakdown of patients. And there was no difference in surgical complexity across all our scores. We wanted to make sure that there were not other facets other factors at play which could have skewed our results. And so we investigated other non-opioid medication administered in the first 2 days after PACU discharge, and there was no difference between the CYP 2D6 categories in this regard. In addition to the complexity of surgery and non-opioid medications used, there were some other key factors that were unchanged between groups, including length of stay, number of MME prescribed, and patient satisfaction with pain control. And in addition, there was no difference in the type or amount of opioids given during the surgical procedure between groups. So we had some interesting findings. In the first 24 hours after PACU entry, patients in that ultra-rapid metabolizer group consumed the most MME, with a median of 75, and this was compared to the other 3 groups where the median was between 20 and 40, and there was a p-value of 0.03 for that. And there were also significant differences between groups in pain scores, with in the last 24 hours of the hospitalization, with the ultra-rapid having a median pain score of 4.9, and the other 3 groups being between 2.3 and 2.9. Although these values on this slide were not statistically significant owing to the small numbers in our ultra-rapid category, as I'd said, there was only 3, there was a signal of ultra-rapid metabolizers using more MMEs even once they were discharged home. And of course, we need further studies with larger numbers in this ultra-rapid category to determine whether this is truly a signal or just noise, but it does give us a direction to move forward. So in this study, we were able to demonstrate that in our cohort of patients undergoing laparotomy for gynecologic pathology, there was a positive association between CYP 2D6 activity and both in-hospital opioid requirements and higher pain scores in the last 24 hours of the hospitalization. And when the immediate postoperative pain is abated somewhat, and many patients no longer need opioid medications, like in our 2013 ERAS study. This exploratory pilot is not without significant limitations, which we have to recognize. The retrospective nature and our sample size limited our ability to perform a robust statistical analysis, especially of that ultra-rapid category. And we also know that in the time since we started this study, other genes have been identified as possibly important in opioid metabolism, such as the ones, the OPRM1 and the COMT that I mentioned earlier. Another aspect that is important, but which we could not explore in this study, is the practical aspect. So financial concerns with the test not being covered, patients having concerns about their genetic information being in the chart, even though this is not really the kind of thing that we worry about as physicians, patients do worry about it. Lag between testing and results in the context of a relatively urgent cancer surgery, and the current inability of our medical record to integrate this kind of data into our daily practice. Of course, we also must discuss the strengths, which is that this information is a treasure trove for the possibility to really individualize our postoperative pain control. In the last few years, there's been an additional investigation at Mayo Clinic with similar results involving several different surgical types, such as breast, orthopedics, and minimally invasive hernia repair, which showed trends toward lower levels of patient satisfaction with pain control in the normal versus the intermediate groups, and increasing opioid consumption with increasing activity score. And interestingly, in their study, which was a lot bigger than ours, it was about 500 patients, they had 0 in the ultra-rapid category. So we know that's a rare category, but maybe the one that we really need to investigate. Looking closely at our normal to poor metabolizers, could we give those patients even fewer opioids at discharge? Might we want to test all patients with a history of opioid intolerance or increased requirements? And in the future, we could also look at patients' side effects from opioids and better determine which patients are at the highest risk. So, in summary, pharmacogenomics is a really exciting field in the context of ERAS and post-op opioid use. That CYP2D6 category really correlates with pain score and opioid use, and with even bigger studies, I think we could prove that even more. And of course, future studies and standardized integration will guide our practice. So thank you again for allowing me to discuss this exciting topic with you this morning, and may we all become Antonio Brown. Thank you.
Great, thank you, Dr. Glazer. So I think our next talk is by Dr. Carrie Langstraat. She unfortunately couldn't be here today, so she taped her presentation. I think we're just going to go ahead with the video, hopefully.
Morning. I'm Carrie Langstraat, a gynecologic oncologist at the Mayo Clinic in Rochester, Minnesota. I want to thank the Program Planning Committee for the opportunity to speak with you this morning. I am very grateful for this opportunity, and I'm very sad that I cannot be there with you in person today. I'll be talking with you about enhanced recovery after surgery in patients undergoing cytoreductive surgery with heated intraperitoneal chemotherapy. I have no disclosures. This morning, I hope to be able to review the potential role for enhanced recovery in patients undergoing cytoreductive surgery with HIPEC. I will discuss the current literature addressing enhanced recovery in this patient population, and I'll outline areas that could use further clarification to really define the role of ARIS in patients undergoing cytoreductive surgery with HIPEC. This group is very familiar and really understands the role and benefits of enhanced recovery. Enhanced recovery is a pathway which aims to attenuate the pathophysiologic changes which occur during and after surgery to hasten patient recovery. ARIS pathways have been shown to decrease hospital length of stay, decrease opioid use, and overall improve patient outcomes. In addition, these pathways have been shown to cut healthcare costs. In this multi-institutional study of 2,372 patients undergoing cytoreductive surgery with HIPEC at 12 major academic centers, we see significant variations in practice. The group found that there were variations across centers and within centers, with no set standard or best practice for management of patients undergoing cytoreductive surgery in HIPEC. For example, as seen in this table above, in the use of postoperative nasal gastric suction and NPO status. Looking at these two variables, we see that the median time for NG2 placement and NPO status were 3 and 4 days respectively, and that the range was 0 to 6 days for both of these. Looking at the fourth column there, or the fifth column there, we do see that there was some variation across institutions, but that there was more significant variation seen across the various institutions themselves. So about 15% of the variation can be attributed to different institutions and their different practices. The authors of this study concluded that additional studies are needed to guide best practice for enhanced recovery pathways in patients undergoing cytoreductive surgery and heated intraperitoneal chemotherapy. When I started using heated intraperitoneal chemotherapy for my patients undergoing cytoreductive surgery for ovarian cancer, I took a step back to see how our enhanced recovery pathways that we use for patients undergoing ovarian cancer primary debulking would apply to our patients undergoing heated intraperitoneal chemotherapy. And some concerns or considerations came from that conversation. And it was a conversation I had with our anesthesia colleagues as well as our surgical oncology colleagues that do quite a bit of HIPEC at our institution. And some concerns that we have were fluid management. We know that heat as well as intra-abdominal administration of chemotherapy alters the capillary permeability and changes volume status, causing some fluid shifts throughout the surgical case. In addition, we identified questions that are not clear, that there are no clear recommendations for management regarding the chemotherapy used throughout the case. So for instance, when we look at specific chemotherapies, they have various side effect profiles. So we had many questions about the safety of enhanced recovery when we were considering using that in our patients undergoing cytoreductive surgery with HIPEC. This study, or this table here, just shows the various chemotherapies that are often used and the side effects. And I want to point out specifically that when we think about using cisplatin intraperitoneally, we have to really consider nephrotoxicity. And we know even given intravenously that we need to sometimes use renal protective agents to prevent nephrotoxicity in our patients. So as I was thinking about how to implement ARIS into our patients undergoing HIPEC, I thought about the three key elements. First, pain control, second, early feeding, and third, euvolemia and maintenance of normal fluid status. So first, looking at pain control. This is a retrospective study done by Webb and his group of 130 patients. 49 patients were included that were pre-ARIS and 81 post-ARIS. And in their group, they used multimodal analgesia to help with pain control. Their group of patients underwent open and laparoscopic approach to cytoreductive surgery and HIPEC, and chemo was administered using mitomycin C with or without cisplatin. One of the elements they used in their multimodal analgesia was a TAP block. In this group, they saw a significant reduction of oral morphine equivalents from total use of around 270 oral morphine equivalents down to around 160. This data was also seen, or this finding was also seen in the group led by Martin et al. In this group, they used multimodal analgesia and opioid-free analgesia, including gabapentin, Tylenol, celecoxib, Pepcid, Precedex, ketamine, and magnesium. They also utilized a postoperative epidural. In this group, they also saw a significant reduction in oral morphine equivalents from 856 down to 156 in the post-ARIS group. They also reduced their homegoing prescriptions from 92% of patients receiving an outpatient prescription to only 55%. So this data clearly shows that we can improve our patients' opioid use by using multimodal therapy. This still does not define the role of epidural, nor does it address patient-reported outcomes when it comes to pain control. Moving forward to early feeding, as I had discussed previously, the chemotherapy agent, which is used throughout the case, can have impact on the patient's ability to eat after surgery, specifically looking at high doses of cisplatin, which can cause significant postoperative nausea and vomiting. So there's, not only is there the chemotherapy complexity, there's also our dependence on NG tubes when we are looking at patients that had multiple bowel resections or had a very proximal bowel resection. There's physician preference when it comes to feeding as well as to NG tube use. We also have patients that are at high risk for ileus. They have long complex surgeries, and that is a setup for ileus, nausea, and vomiting after surgery. But the benefit to early feeding has been clearly demonstrated in other ARIS studies, showing that early feeding is associated with a decreased length of stay. There are multiple studies which look at early feeding in patients undergoing HIPEC, and these different protocols include preoperative carbohydrate load, removal of the NG tube on post-op day 1 or no use at all, and early feeding. And they have replicated the data showing that the early feeding did decrease the length of stay and had an earlier return to bowel function. In the study by Siddharthan, they saw a decrease in time to bowel function from 5.5 days to 4 days. This was similarly seen in Martin's study, which showed a decrease in bowel function or earlier bowel function on day 4 as opposed to day 8. So again, showing early feeding is feasible and likely safe in this group of patients. And finally, euvolemia. This is a more complex problem. In this study by Liu et al., they took their patients undergoing HIPEC with mitomycin C. They had goal-directed fluid replacement with the aim to maintain urine output of 0.25 milliliters per kilogram per hour. They also discontinued IV fluids after 6 hours after surgery, giving only fluid boluses as indicated by symptoms and clinical findings. And in their group, they significantly reduced their total intraoperative fluid use from around 900 milliliters per hour to about 500 milliliters per hour. This reduction was primarily in the use of crystalloid. They did not see any evidence of renal injury. However, this group, again, was all treated with mitomycin C as opposed to cisplatin. In this study by White et al., they used goal-directed fluid management. They had crystalloid at 3 milliliters per kilogram per hour, and they used 500 milliliters of 5% albumin. But they added sodium thiosulfate, mannitol, and magnesium as renal protective agents for patients being treated with cisplatin. So it's again a retrospective study. They saw no change in mortality. They actually saw an improvement in the risk of acute kidney injury. They decreased the incidence of acute kidney injury from 18.2% to 7.5%. This was seen primarily in the patients undergoing HIPEC with cisplatin. So this study also suggests that it might be feasible to reduce the use of IV fluids during and after surgery if appropriate renal protection is used. Now, if we're going to make all of these changes in our protocols, we want to know that it's helpful for our patient outcomes. So what is the impact of ARIS in this group of patients? In a meta-analysis by Mao, they took 7 studies and looked at the length of stay, and they saw an improvement in the overall length of stay, favoring ARIS. They also saw a slightly lower risk of grade 3 to 4 complications in patients undergoing enhanced recovery. Additional outcomes evaluated in the meta-analysis included readmission rate, reoperation rate, acute kidney injury, and mortality. And they saw no change in all of these outcomes, but did see maybe a slight leaning towards favoring HIPEC for most of these outcomes as well. So the meta-analysis, looking at the 7 best studies we have on ARIS in patients undergoing cytoreductive surgery and HIPEC, shows some improvements in outcomes and shows feasibility and safety of enhanced recovery. So as we move forward, what can we do? How can we adopt ARIS pathways in our patients undergoing cytoreductive surgery with HIPEC? I think there are a few things that we can adopt with confidence. There are many preoperative and intraoperative interventions which are not included in this presentation, which can be adopted. In addition, use of non-opioid analgesia and multimodal analgesia, intraoperative and preoperative, should be easily adopted and accepted. We should monitor cardiac output and use that to help us manage our fluid status throughout surgery. We should educate the patients on the importance of enhanced recovery, and we should also be aggressive about antiemetic treatment. In the postoperative setting, we should adopt and continue to use multimodal analgesia. We should continue to do the antiemetic therapy. We should plan for early removal of the catheter with early mobilization, minimize the use of NG tube, and plan for early oral intake. Now, where I think we have ongoing questions is we need to further understand the safety of goal-directed fluid management, specifically looking at patients being treated with cisplatin. We need to address the role of renal protective agents when treating patients with cisplatin. We should identify the need or potential use of diuretics to maintain urine output goals, as these have been used in the past, but may and likely do increase our risk of AKI. We need to further delineate the role of epidural analgesia in these patients. It does seem that our patients undergoing treatment with HIPAC have increased pain levels, but we really need to study this more, looking at patient-reported outcomes and looking at epidurals versus tap blocks versus alternative pain management strategies. And then finally, we need to address the use of NSAIDs both preoperatively and postoperatively for our patients undergoing treatment with cisplatin. And as we look at these problems or questions moving forward, it's important to, again, remember that ARIS is a multidisciplinary and multimodal approach, and we should really look at our goals to improve patient outcome and align these with our oncologic goals for our patients. Collaboration and stakeholder input is going to ensure that we can be successful as we move forward with ARIS in our patients undergoing cytoreductive surgery and HIPAC. So in conclusion, there's definite room for improvement in patient outcomes in patients undergoing cytoreductive surgery and HIPAC. Preliminary data suggests that ARIS is feasible and safe in cytoreductive surgery and HIPAC. Finally, we need more data to help drive development of ARIS pathways in patients undergoing cytoreductive surgery with HIPAC. Thank you for your time.
Okay, next we'll have Dr. Kevin Elias come and speak to us about strategies to improve compliance. And I guess he needs no introduction, so thank you for coming to the stage and speaking to us about this. This is often the Achilles heel to our ARIS pathways.
Thanks, Sean. It's kind of interesting that I'm giving this talk during the gynecology section, because I don't think this is a gynecology-specific topic at all, which actually works out well for me, because that means I can use this talk again for general ERAS meetings. And so again, we're going to be looking more higher concept here, talking about improving compliance with ERAS, like I said, quite generally. I don't really have any financial disclosures of interest here. I will discuss some software, though, by name. Not that gives me any money, but just so I acknowledge that. We have to define what compliance actually means. It's a term that we toss around quite a bit. It's almost never defined in papers, actually, what they actually are referring to. What's our goal with compliance? And then how and why should we improve it? So we're going to define compliance. That might seem very obvious, but I did a search of various ERAS papers, and actually the ERAS guidelines use compliance, I think something like 25 to 30 times per guideline, and I couldn't find any of the ERAS Society guidelines that defined compliance as far as what that term actually meant. So it's interesting. I really distinguish between these three concepts of benchmarking, adherence, and compliance, and they often get conflated. Benchmarking is identifying the best achievable outcome. And so benchmarking is a measure of quality. The Dutch surgical colorectal audit's a great example of a benchmarking study. You look at every hospital in the Netherlands that's doing colorectal surgery and who has the best outcome, the lowest rate, in this case it was of a positive surgical margin. And you say that's the benchmark. That's what we should be striving to achieve. That's very different than what we're doing with auditing and compliance. A good example of those two concepts would be the Australia PCI study, right? These are patients, this is post-MI care. So they look at adherence, which is an active participation, versus compliance, which is actually passive. So compliant, if you're running a post-MI program, is how many times did you prescribe a statin and a beta blocker and an aspirin after the patient left the hospital. Adherence is how many patients were taking the drugs. Those are very different concepts. And so depending on what your goal is with an ERAS pathway, you might be very compliant, but you might not be very adherent. And we want to differentiate those things. So as I said, compliance is passive, but auditing compliance, now this is an active process. We had a nice talk from Dr. Bish earlier about the role of auditing. And so this is, I think, a paper that gets cited a lot when we talk about enhanced recovery, even though it has nothing to do with enhanced recovery. But this is looking at ventilator-associated pneumonia, so active versus passive guideline implementation. So this was a bundle that was rolled out for reducing VAPS, and they went through a passive implementation period. Here's the bundle. It got posted in all of the ICUs. Everyone did their mandatory health stream or webinar about it, versus an active implementation period where they were actually auditing results. And not surprisingly, in the active implementation period, the compliance with the various elements was significantly better pretty much across the board. Now, there's a punchline to that, which is if you looked at the passive implementation period, which was the publishing of the protocol and handing it out, versus the active implementation period, yeah, the mortality from VAPS only went down during the active implementation period. So just having a protocol and emailing around about it, that's not the same as active implementation. So we were talking earlier about people not necessarily seeing results with enhanced recovery. Well, that depends if they're actually doing enhanced recovery. If you don't actually do it, it's not going to make a difference. This is a quote that's usually misattributed to Aristotle. It's actually not an Aristotle quote. It's a quote by a biographer of Aristotle in the introduction. But it's still a good quote. We're striving to maintain a habit of excellence, right? I think that's really summarizes enhanced recovery in a nutshell. These should just become second nature. Sort of like we heard in the bowel prep discussion earlier, you've never given a bowel prep. I wish I could say I've never given a bowel prep. That would be lovely. My colorectal surgeons occasionally force me to do it, but I rarely give one, I will say. But it's still good to make that your habit. So how do we measure compliance? So the elements that we measure should reflect best ERAS practices. And again, we heard a little bit of this in the first talk. Are we measuring something because it's easy to measure or because it actually drives better outcomes? This is a fight I have at a hospital administrator level all the time. It's much more convenient to measure the things that are automatically exported by the EHR. It's much harder to measure the things that require human assessment, but they're the ones that tend to actually relate to outcomes. At the same time, you can measure too many things. There is audit fatigue, right? So measuring 300 variables is probably not quite necessary. But I do think when we're looking at compliance, you want to try to choose binary variables. You're either compliant or you're not. There's a lot of gray area sometimes of, well, should we call this one compliant? You need a strict definition so that things are not subjective. Engaging with compliance data, I think compliance has 4 elements. The data need to be relevant, the definition needs to be clear, you need to have feedback, and you need a real database. Please don't use an Excel document to keep track of your enhanced recovery. So what's the goal? So we've talked about what compliance is. I like this quote. I don't necessarily like the person who gave the quote, but it's a good, again, it summarizes a lot of the problems that we deal with. If you're constantly reviewing your ERAS cases and you sit there at your ERAS review meeting and you say, well, this patient wasn't really on ERAS because of X, Y, and Z, and well, this person wasn't compliant because they had all these reasons. If you're making exceptions every single time, then you probably have bad metrics that you're using or a poorly defined protocol. So I would always be wary when everybody seems to be an exception to the rule. And this has to do with checking the box versus meeting the goal. So these are 3 elements I pulled off from the recovery checklist that we heard about earlier. Patient education regarding the ERAS protocol. Okay, so there's 2 ways to do that. You have a pre-populated sentence at the bottom of your H&P that says patient was educated about enhanced recovery, versus do you actually have some demonstration that the patient attended a preoperative class or enrolled in an app if you use a patient-facing app. again, it's a passive versus an active compliance. Anemia screening, did you document the hemoglobin pre-op, or do you actually have an anemia clinic that the patient actually went to? So which of those do you consider to be compliant? Yes, you screened for anemia if you documented the hemoglobin, but if you didn't do anything about it, that's probably not sufficient to actually improve outcomes. Same thing with tobacco cessation. The number of patients who actually get referred to smoking cessation programs, at least at my institution, is like maybe 5% or fewer. Not a lot of patients smoke in New England either, but still, it's not very high. There's a nice study on this where they looked at active and passive compliance in an enhanced recovery program. So they defined a passive element as something that did not require the patient to participate, and an active element required the patient to participate. And they said, which of these actually gives you more bang for your buck? Interesting question. This is on colorectal. So what they found was actually, if you looked at the area under the curve, is how they measure this for active compliance versus major morbidity, it was the active elements that actually made the bigger difference. The passive elements, that's pretty much a straight line. That's a flip of a coin. You talk about an area under the curve. But it was really the active elements. What were the active elements? Carb loading, taking the catheter out, putting the patient on some sort of bowel regimen, getting the fluids off, putting them on oral meds, solid food. The things that nobody really had to do, like avoiding an NG tube, I mean, that didn't make as much of a bang for the buck. It was the things that required active participation. Engaging patients for active elements. So strategies for doing that, something I talk about sometimes, are using apps. This is an app that we built for our gynecologic oncology patients specifically, which we found was quite effective for getting patients engaged in enhanced recovery. The other thing that we did a study on recently was figuring out patients who were compliant versus not compliant, or adherent versus not adherent, I should say. And language was a big driver. So this is what's the slide I most commonly get requested. It's the placemat, as we refer to it. It's we have this laminated in every room in the hospital. Patients also get it in pre-op, setting the expectations for the patient about what the enhanced recovery program will entail. So now we just translated this into our 5 most common languages, which at my hospital is Chinese, Arabic, Russian, Portuguese, and then Spanish. So this is the one in Mandarin. And again, not shockingly, the patients who were not primary English speakers tended to be the ones who didn't do as well in the pathway. So this was a way to mitigate that. Do we need full compliance? Another interesting question that came up. So again, from the colorectal literature, and they divided compliance into the less than 70, 70 to 90, greater than 90. And they actually did find that actually patients who have greater than 90% compliance do better than our conventional benchmark of 70 to 90, that there do continue to be benefits. And again, compliance is always a funny thing because sometimes we're measuring both an outcome and a process measure at the same time. So for instance, mobilizing on the first day of surgery, well, it's both, in the sense of it's good for the quality of the patient's recovery, but it's also one of the metrics that we use to be following the pathway. And the biggest thing they found was that the complications really went down when you got to that greater than 90% group. So then you want to enter a constant improvement cycle when it comes to compliance. You can't just sit still and assume that your ERAS program is going to take care of itself. So there's different tools for assessing compliance and visualizing data. There's the ERAS Interactive Audit System, which we've been using now for several years. We have more than 1,000 gynonc patients in that system from our institution. Or you can use a REDCap database, and this is what showing here. We use a heat map that we display every month when we go over our service-specific data, looking at the number of cases and people complying with different elements and trends over time. There is some nice data from our friends down at the Carolinas about using a REDCap database. Does it actually make a difference to engage actively with the data? And they found that using a REDCap tracking system actually led to better compliance with outcomes after their Whipples. So the audit can be an intervention when you're doing enhanced recovery. And then we, as a society, led by Greg and Sean both, we did a validation of the ERAS guidelines using some of this compliance data, and we showed that compliance actually does track with length of stay and complications after major gynecologic surgery. The thing I think is most important is meeting often. So I meet with the nurses on my unit every morning, every Thursday morning at 10:15 is ERAS huddle. Here's me with our nursing team. We review every ERAS case from the previous week. And we focus on pain and nausea, ambulation, diet, go through complications. Why didn't this patient do well? And the most important thing is we recognize the nurses who do a really good job. I know the name of every nurse in my unit. I think I'm the only one in my group who knows the name of the nurses, every nurse in my unit. There are 35 nurses who work in my unit, 3 shifts. And I know because I read all of their notes, and I recognize the nurses who do well and the ones who don't. And I think that's made a big difference as far as getting people engaged in the pathway. They know that they're being recognized for doing well. Same thing with the anesthesiologists. I call out the anesthesiologists who do a good job and the ones who do a bad job by name. And I email their boss. But it allows us to do rapid problem solving, which is good. And this takes 15, 20 minutes every week. That's it. You know, it's not that many cases to review. We also, again, we meet often. We have a surgical quality committee that meets every month. We go through every service line and their compliance with various elements, such as like carbohydrate loading across the various ERAS pathways we have. We do surgeon report cards quarterly. Every surgeon in the group. How are you doing? What's your trend? How are you comparing everybody in the group? How do you do for each individual metric that we consider to be within the surgeon's purview? Public shaming is a very effective device. So in conclusion, compliance is a habit. And I think that that's really what I would stress. But you need frequent auditing to avoid complacency. Measure compliance to improve outcomes, but it's really the active elements, the hard elements of ERAS are the ones that make the biggest difference, and frequent feedback is key. We can do well, but we can always do better. So thank you very much, and I've really enjoyed this session.
Questions here, yeah. Thanks, Kevin. I think it's fine. I'm going to kick us off. I just have a couple of questions for our speakers today. Again, I appreciate everybody hanging in here with us. I think there's been a lot of really interesting and innovative talks. Maybe I'll just start off with Steve. He's probably thinking, oh no, what's coming? The question I had for Steve, you know, a lot of the literature is based on sort of pre-post studies, and there, you know, has been some criticism of that. But also recognizing that we can't necessarily do randomized controlled trials on every part of ERAS, not just in terms of outcomes, but also every individual element. When you look at the literature and you're trying to figure out outcomes assessment in ERAS, is there a better way that we can conduct some of these studies? And maybe I'll get you to give us your thoughts on that.
So thanks for the question, Greg. I think there's different ways to control for confounders in the literature, and an RCT is an excellent way of controlling confounders by randomizing people just based on chance. When we're dealing with pre-post studies, there's ways to minimize the confounders between the groups. Basically, there's differences in the group that might account for the change that you found, but have nothing to do with your intervention. And we sometimes refer to these as sort of, you know, there's different selection bias, but there's secular events that change. And I think the big thing we all need to take into account is COVID. And so that is a massive change that's happened within the span of a couple of months in some places that can dramatically influence what our outcomes are going to be. And so when we do a pre-post study, which as ethics, you know, as ERAS is demonstrating benefit, it's going to be harder and harder not to do randomization because there's no equipoise. We need to start looking at patient factors. So the complexity of the surgery, patient complications, the advancement or how advanced the disease is. And you can either do that through randomization or attempt to do it with statistical measures. The thing is, you need to measure the differences before you can statistically adjust for them. And so one thing that people really need to keep an eye on is, as COVID came along, we're going to be looking at patients who are we're doing surgery for the patients who have the most advanced disease. And we're probably going to be prioritizing and triaging, and that's going to dramatically alter our outcomes unless we can adjust for it. So what I would say is we need to be measuring the potential confounders, and that's common sense. We're surgeons and clinical care providers. We know what can affect our outcomes, so measure them, adjust for them statistically whenever you can, and be aware of those secular trends that might change your outcomes. That'd be sort of my takeaway point.
Awesome. Great. Thanks, Steve. Chris, I have a question for you, if you don't mind coming up to answer. So, you know, I think I've got a really good relationship with most of the anesthesiologists that I work with. And unlike Kevin, I have not had the opportunity to kind of email them and tell them if they're good, if they're bad. And I'll say, I can say that I've never given a bowel prep, but I have to say I don't know the name of every single nurse, and I also don't meet weekly, so kudos to you. That's probably huge. But you know, there's always that situation where you enter the operating room on a particular day and you know maybe that anesthesiologist is not the greatest supporter of ERAS, or you know there's going to be lower uptake of what you want to achieve. So I guess the question is, how do we get around the idea that, you know, at any given institution there could be 40 to 50 anesthesiologists that we encounter just randomly? And how do we address that barrier? And should we have ERAS anesthesia teams? And is that even possible?
That's an excellent question. It's the real question, and I think it cuts across all aspects of enhanced recovery care, not just surgeon anesthesiologists, but in the pre-op area and the post-op area. I think it's been mentioned earlier in this meeting that this ought to be the standard of care. We're moving past the point where this is kind of a rogue sort of practice, and within our group, there's various degrees of enthusiasm about it, but as I was talking about during my lecture, you have to meet folks where they are, and I think it's okay to not impose controversial aspects of the protocols on everybody, and just find something that the entire group can get behind. There's a practice, many people here probably don't know the Seattle Children's outpatient practice, but some probably do. I see at least one head nodding. And before ERAS existed, they started working on improving their processes for care. And they had to take an incremental approach. And they actually lost some anesthesiologists because they wanted to standardize care. And somebody left because they didn't like the choice of opiate that they settled on for tonsillectomies. It was really pretty sad. But I think the beauty of enhanced recovery is that it reduces variations in care. And to improve a system, you can't begin to make improvement until you've got a stable system. And if your stable system isn't ideal, at least it's stable. And so this is, I guess, it's kind of a roundabout way of saying that there's going to be variation in people's enthusiasm about it, but if you start off doing things where people are, you can begin to move the needle more slowly over time in that direction. It's a lot of work.
And Chris, can I just ask you one other
Yeah.
question before we go? So surgeons talk to surgeons, anesthesiologists talk to anesthesiologists, or they take things back, like our local ERAS anesthesia champion.
I will kind of give a brief to him, and then he'll say, okay, I'll go back to my group and we'll talk about it at our business meeting, and then I'll let you know if they're going to, try to increase compliance to this particular thing. When you talk to your anesthesia colleagues, like what are some of the top beefs that they have about here? Like those ones that don't want to do it. Like what is it that they say is garbage, I guess?
I don't think that any of ours think any of it's garbage.
Okay. That is Mayo, though. So
Yeah, and we're all kind of sheep at Mayo. Yeah. I think everybody wants to do a good job caring for patients, and at its essence, enhanced recovery is applying best practices to care of patients. That's all it is.
Yeah.
And I think, we're in a bit of a privileged situation because we're an academic center and everybody's kind of up on the literature, but I've done some work in our community system, and when we talk to some of the providers out there, oftentimes they were just unaware of what the current literature was, and it was simply a matter of educating. So I know that it's out there, that people are resistant, but I think a very, very systematic approach to just educating and keeping the focus on patients is what it takes. I think if I go to a surgeon and say I'm going to do a spinal for this patient, and the surgeon hates spinals, you know how that's going to end up, right? But if I go to him and say, you know what, in this particular patient, for this particular reason, I think that they will do better with a given technique. It's much more accepted.
We'll go to the mics.
Yeah.
Thank you so much, because you just created a phenomenal session to be held next time on how to move enhanced recovery to become, like you say, the standard of care. And we should not ask for anything less. 2021 switch, the last two numbers was the first ERAS Society meeting, and the path has been incredible. The data exists. We should turn up the volume and have really hospital leaders, health system leaders, insurers, patients endorse enhanced recovery and get people on the bandwagon that way. Give feedback often, right? And tie bonuses to outcome, to quality measures, right? We do this already. If your patient is warm, if you participate in certain key quality improvement sessions, stuff like this, right? And the last thing I'm wondering is whether it is still appropriate to have departments of surgery, anesthesia, and so forth, because we are working around and for the same thing. Yeah. And when you say anesthesiologists talk to anesthesiologists, surgeons talk to surgeons, that's exactly the problem. We shouldn't be talking in silos anymore. We should be talking about what we are dealing with from day to day. Thank you.
Yeah,
That's a great point.
I think that was beautiful. That was probably the most wonderful summary, that we shouldn't talk in silos.
I think it's just a love fest here this morning. Okay, keep going.
I work in private practice. We are a group of physicians who are contracted with the hospital, and the hospital wanted us to implement ERAS, and basically implement it now. They had been asking for a while. It hasn't happened, despite literature, despite people being motivated and informed. It just didn't happen. So the hospital said, you're going to do this, lest we're going to have a different group contract with us. But even that was not enough of a motivator. So I think it's interesting. It's very difficult to motivate people to change. We talked about that earlier too. But we had to actually form an ERAS anesthesiologist group. And within that group, we're trying to keep the commitment to follow as many of the guidelines as possible. So I think there's maybe a difference between academic centers and private practice. I don't know if you have any insights into that. I think it is just very, very difficult to tell people what you have been doing for 20 years is not good anymore. I think that is the biggest hurdle. It's not like they don't care, but they would have to say, I have been wrong, perhaps. And so how to sweeten that deal? I think that is the question I have. How can I get all my friends and colleagues on board so that we are all providing care 24/7 rather than within that dedicated group during regular hours? And so there might be a difference, and I would love to hear from you how one could negotiate that.
We were discussing after the board meeting the other night what we ought to be looking at next, and change management is really the most difficult part of this. I think, maybe by virtue of dumb luck, we haven't had a lot of problems, because when we went to our healthcare system, they were all private practitioners. But we took a very stepwise approach, and some of it was peer pressure. For example, we would approach things in the way we normally do, which is essentially an enhanced recovery approach for all our anesthetics. And the surgeons were happy, and they would say, well, the guys from Rochester are doing X, Y, Z, and their patients seem to do better. Would you consider doing that? I don't have any magic bullet for this. It's a long stepwise process, and this thing at Seattle Children's, to get to the point where they are approaching their ideal state, it took them 11 years. Right, it's not just a flip a switch and we're going to do enhanced recovery or whatever you want to call it. It's this attitude of continuous improvement, and I think for broad adoption of this stuff, that's probably the approach. Now, this isn't the official ARIS company line, but I think that approach of a stepwise adoption may be more effective to get it broadly applicable.
Hi, yes, I'm from St. Louis, and I'm actually here because of the hospital and a steering committee commitment to get ERAS. And I can say, I think we are breaking down the silos, because the Department of Anesthesiology is now getting all the service lines in line. But you mentioned that there is you said something about ERAS unit with the nurses there. I mean, is that just a floor with all the ERAS patients there? I mean, I'm trying to figure out what to do with the nursing side of it.
Probably some of my colleagues from GYN surgery in Rochester can answer this better than I can, because they never let us out of the ORs. But this is clearly a team approach. And the comment about we need to get rid of silos includes not just various physician specialties, but physicians versus nurses as well. I promised the gang last night at dinner I wasn't going to talk about the Green Bay Packers, because I'm a Packer owner. I'm an NFL owner. But the comment about getting rid of silos is just like a sports team, right? The quarterback and the linemen, they all talk to one another, right? And we don't do that well in medicine. So when we adopted our project in GYN surgery in Rochester, there were nurses at the table. And Sean and Jamie can speak to this more than I can, but because they deal with them on a daily basis. But a lot of it was buy-in from the nurses, and we had to take what their concerns were into account. And at the time we did it, there was nothing really in the GYN literature to suggest that this was a good thing. This was in colorectal only in those days. So I don't know if that answers your question well, but that's what I've got. Kevin probably has something.
Thanks, Chris.
Yeah, no, I think it's a good point. So we don't have an ERAS unit per se, but there are service lines that have pushed enhanced recovery more than others. And what tends to happen is those nurses get used to managing patients with enhanced recovery. They see that the ERAS patients are doing better than the non-ERAS patient, or the service lines that aren't doing ERAS, and then you sort of get a spillover effect. Certainly within my hospital, there are floors that are more ERAS friendly than others. I mean, just by practicality, right? In other words, there are surgical floors, and then there are patients that get floated over to a floor that's usually dealing with medical patients, and they're just less familiar with enhanced recovery. So, some regionalization is helpful, but what's actually quite helpful is to try to minimize the arbitrary variation among the service lines. So for instance, take this off for a sec. For us, I sat down with our colorectal colleagues and our urology colleagues, and we realized, well, it doesn't make sense that one of us says to keep the fluids at 75 cc's an hour and the other one says 100 cc's an hour. Like, let's come up with a value, because that just made life hard on the nurses, because they had to figure out, so that now essentially all the pelvic surgery cases have more or less identical management strategies, and that makes compliance better because the nurses are more consistent. We also just ask the nurses, how can we make the orders easier to interpret, right? And then you get a whole list of conflicting orders that they tend to see and have to deal with, and then you realize that you can make life easier for them by just how things are written. So it's not a unit per se, but consistency helps. The other thing that helps is having a couple nurse champions and like bringing them to the table, as Chris said. Bringing them to New Orleans helps too. Unfortunately, none of our nurses came this year, but in the past we've had quite a few who have come down to the meeting here, and that really makes a big difference because they want to be recognized for being at the bedside and what they do. I'm not the one getting them patient up at 1 o'clock in the morning and forcing an Ensure into their hand and making them walk down the hallway, but they do it.
Yeah, great session. Thank you so much. A quick comment on that, and we are hearing about shortages of nurses. The UK, which is always cash-strapped, would implement ERAS with one nurse, and you need that nurse to be very well respected by their colleagues out on the floors, but you can start a lot with, you don't need a whole team of nurses. So just a comment. Couple of questions, one for you, Kevin. What do you say to the reviewer, and I'm sure you've experienced this, who says, well, it's obvious, it's just the Hawthorne effect when you do your audit and
Right, this comes up a lot. The fact that you're measuring something, things got better because you measured it. I think it depends on what the outcome you're looking at is. In other words, we do try to be careful that, for instance, like let's say that we're measuring, mobility on day 0. Right? Is it getting better because we just improved documentation and the fact that we were measuring it? Can happen. That's not necessarily a bad thing, I don't think. I don't think the Hawthorne effect, leads to fewer patients having AKI and vomiting after surgery. So I think it just depends on the outcome. Yeah, but you're right. You do want to make sure that your metrics are reflecting actual differences. Yeah.
Thank you. Yeah. And a question for Dr. Glaser. What did you see? You mentioned side effects, but I don't think you showed the data. Can you comment on nausea and vomiting, or severe side effects?
Gretchen, do you want to come on up here?
We did not specifically parse out nausea and vomiting for this particular study, but I think it would be a great thing to look at in the future. So, for this pilot, we were just trying to see, is there any difference? But we didn't look specifically at nausea and vomiting. But I would be really interested in nausea and vomiting and also dependence to see if the ultra-rapid metabolizers are truly the ones who become more dependent in the future. The other thing I just wanted to mention in terms of change management is just with my other hat as the residency program director, our residents are key in keeping our ERS elements going. So they have it's like they learn the rules and they know the rules, and if anyone goes outside of it, they're right on them. Calling nurses, how come that catheter's not out yet? How come they're not out of bed? And they're so just indignant and proud about it. So I think we shouldn't forget that we have this kind of intermediary group who can be really, really good at helping us to keep our compliance up. So.
Awesome, thank you.
Thanks.
Well, I think I have 13 seconds to close the session. So guys, thanks so much. It was really, really exciting, and just really happy to have everybody here and join me today. So thanks a lot.